Welcome to another Tulane University School of Medicine Community Town Hall discussing updates on COVID-19. I'm Lee Ham. I'm the Dean of the School of Medicine. It's been a pleasure to have these town halls, hopefully by providing more information. We're providing some useful information to the community, hopefully providing some relief of concerns by having more information. There's some good news and reason for continuing concern. This slide shows the global impact of COVID-19 and shows that we're above 2 million cases globally, and that the United States has more than 600,000 cases and is by far and away the country with the largest number of cases. And on the right hand, you see that Louisiana has also been highlighted, and this shows the number of cases, the number of people that have been tested. And that's a really good thing. Louisiana has done extremely well compared to the rest of the country in terms of the number of people relative to the size of the population and getting people tested. We still have a long ways to go, but we have had more than 100,000 tested. This shows more the local impact. Statewide, we've had more than 22,000 cases. We've had more than 1,100 deaths. It shows the 120,000 that we've tested. There are cases in every single parish. It shows on the far right that many of the people with symptomatic cases have a variety of underlying diseases, but as you've heard from the news, not everyone. But you can see also in the middle table that, as you will hear more about, that this illness is striking African Americans disproportionately. Even more locally, this shows the breakdown by the regions and parishes of the state. Region 1, which includes Orleans and Jefferson Parish, has the most cases, with more than 5,000 in both Orleans and Jefferson Parish. Region 2, that includes Baton Rouge, the most. So New Orleans has been, and the metropolitan area has been one of the areas that has been in the very highest areas struck by the virus. On a population basis, we rate right up there behind New York and the northern parts of New Jersey. One of the things that we have been most concerned about are those most severe cases and those requiring hospitalization. And here does show some good news. The top line shows the patients in hospitals, and it shows that the number in the state has been beginning to gradually decrease rather, from a very high level, but it's a gradual decrease. And in the yellow line, it shows the number of patients on ventilators. Still almost 400, but a declining line. It does look like we may have passed the peak. But what this reminds us of is a couple of things. One, this is still a very dangerous virus, and that it's way too soon to begin saying party zone, too soon to relax. We have to continue the social distancing. And we're going to have more bad news. We're going to have more people die from this. It's very clear from the number of patients that are still on ventilators and the number of people still in hospitals. Many of those will recover, but some will not. We're still having new patients arrive. Not as many as we were at the peak. That's the good news. But the bad news is we still have a ways to go, and we still have to be vigilant. And we still have to plot a course of returning to a different normal. Tulane has been on the forefront of treating this in any number of ways. For our adult services, we provide major services at 3 hospital systems: Tulane Medical Center, the VA, and University Medical Center with LSU. We've had 28 faculty teams that are comprised of both faculty, residents, and fellows. We've probably treated in the hundreds of patients or patients that were suspected of COVID-19. Many have not required hospitalization, but probably more than 300 at this point in the hospital with COVID-19. We've also been contributors at the convention center. One of our faculty, John Carlson, is the chief medical officer there. We've had intense work from our hospitalists, our pulmonary or lung physicians, our infectious disease faculty, our cardiologists, our surgical intensivists, and many others. We've seen a remarkable degree of collaboration and cooperativity across all healthcare professionals. It's really been remarkable to witness. We've had many patients, as I mentioned, that have been discharged, but still have a ways to go. I wanted to use this slide to tell you some about where the next few weeks, some of what will be happening and is happening. First, a number of clinical trials and research are going on. Some of these involve antivirals, a study sponsored by Gilead, another sponsored by Regeneron, others sponsored by the NIH, several clinical trials going on at each of the hospitals. There's significant ongoing work by Dr. Tony Hu, Jay Coles, Jay Rappaport, James Robinson, and many others about testing of the various types. And I'm going to explain some of the testing in a minute. Several of our schools have been heavily involved. Obviously, I'm speaking for the School of Medicine, but the School of Public Health. In a major way, the Primate Center on the North Shore that you'll hear about. But also the School of Science and Engineering and other schools have been involved in this effort. There are major teams, as you'll hear more about, working on vaccine development. We have experts like Dr. Chad Roy that you're going to hear about, who just got a large contract from the NIH. You'll hear from Dr. Mclaughlin. his colleague, Dr. Marisi, and other experts that are really national experts in vaccine development. This slide also shows in the upper middle where it says PCR antigen test. That's usually what has been meant up until the present about tests for the virus. That's a test where you're testing for active infection. It refers to the polymerase chain reaction where even small amounts of the virus can be amplified and measured to say whether you have an active infection or not. And that's being done by 3 or 4 different ways and is being done at all of the institutions in a few ways. At Tulane, we're doing it where you can have it done instantly in the emergency room, another where we can do large samples, another that we're doing in the School of Medicine laboratories where we can run hundreds per day. There is another type of test that's going to be very important as we go forward in knowing how to deal with the situation to go toward a more normal life. And that's antibody test. That's depicted in the bottom half of the slide. And that refers to measuring the immune response to an infection. The immune system in the body has several components, but one of them that can be tested specifically relates to antibodies. Often you'll hear talked about either IgG or IgM, but ways to test the antibody to know if someone has had an infection. It usually takes several days to develop, so you can be infected and yet be negative with the antibody test. You can have had an infection, cleared of it, so that the PCR is negative, but the antibody is still around and hopefully is providing immunity. You'll likely hear more about this both today and in the subsequent weeks. We have done at Tulane several grand rounds and public town halls that are available for you to go back and watch with many national experts, just like we have on today's calls. So I hope as you want to learn more that you will. And finally, I want to take just another minute and thank all of those that have been contributing so much. Obviously, the doctors, whether it's faculty or residents, the nurses, the technicians, the cleaning staff, the security teams, the cafeteria staff, the students who've been volunteering, the administrative staff. Again, a remarkable effort to approach this virus. Many people doing all sorts of things. And I want to thank so many in the community who are doing so much. From those of you that are mainly sheltering in place, but we've had many donations of the PPE. We've had donations of food. We've had people that are cooking to maintain our medical personnel on the front lines. It's been a remarkable help to them. So thank you to all these individuals and thank you to the community. We are going to get through this because of the concerted efforts. I now want to turn over the presentation to Sharon Courtney, who's been moderating these, who is the Vice President for Government and Community Relations at Tulane University. Sharon.
Was I muted? Sorry.
Okay.
Let's start again. Thank you, Dr. Ham. And thanks to everybody who's joining us on Facebook Live and Zoom. I think we'll get started today by letting our panel introduce themselves. And I'm going to start with Dr. Keith Ferdinand.
Hi, I'm Dr. Keith Ferdinand. I'm a clinical cardiologist, specialized in hypertension, cardiovascular diseases, and I've done research in the area of disparities with particular interest on how racial ethnic populations are affected, not just by COVID-19, but historically with increased death and disability. Sharon, I think you need to unmute again.
I think I figured it out. Is it working?
Yeah, now you're unmuted.
The joys of Zoom in my workshop here. That's great. So, sorry, my name is James Mclaughlin. I have a PhD in immunology. I'm an associate professor in the Department of Microbiology and Immunology here at the Tulane School of Medicine. And my interest is mainly in vaccine design and the immune response to a variety of infectious diseases. Dr. Roy.
I'm now unmuted. Okay, my name is Chad Roy. I'm a professor of microbiology and immunology and director of infectious disease aerobiology at the Tulane National Primate Research Center. And that's what I study and have been for a very long time, is the infectious disease agents and how they transmit in the air and the ecology and transmission patterns as it's associated with infectious disease.
Great, thank you. I feel like we've passed the most crucial test. We've all learned how to mute and unmute ourselves. So, well, we'll see how it goes from here on out. I want to start with Dr. Ferdinand. Dr. Ham mentioned the disparities among race in this disease. And I wanted you to tell us a little bit more about that, both here in New Orleans and how New Orleans potentially compares with other similar areas, if this is something unique to us or something that is happening across the country.
Unfortunately, it's not unique, and it's not just related to COVID-19. If you look at the percentage of persons who die from COVID-19 in the New Orleans area, it's clearly disproportionate, higher than the percentage of the population. But we've seen the same thing in Milwaukee, Chicago, and Detroit. And we've even seen it in the rural area, Albany, Georgia, which is in the southwest corner of Georgia, where you've had a lot of African Americans who disproportionately died from COVID-19. We really don't know all the reasons, but clearly it's related to a toxic gumbo of different health factors, hypertension, obesity, diabetes, asthma, which are higher in African Americans. And then once a person has a viral infection with those higher comorbid conditions, other diseases, they're more likely to die. But there's also what we call socioeconomic disparities, or the social determinants of health. Where you live, where you work, how you live, has also a great impact on life and living itself. For instance, we know in New York, the transit operators, and here in New Orleans, are dying from COVID-19. Grocery clerks and people in food service, even in small cities like Sioux Falls, South Dakota, are dying from COVID-19. We say that a person should socially distance themselves from others if they're infected. But if you have a multi-generational home with a small apartment and dense living quarters, that's almost impossible. And then there's the problem related to myths that unfortunately circulate, especially in racial ethnic communities, about disease processes. And that's why it's important that we always educate our patients to empower them to have a better understanding about disease processes, including COVID-19, and how to avoid some of the ravages of those conditions.
There's obviously, and I'm going to stick with you for just a second because I want to dig a little deeper here. So obviously there's just the disproportionate like health equity issues. What are the things that are there short-term, not solutions, but are there short-term things that we can get into the community to help those communities that are underserved?
Sure, I'll give you a laundry list of things that I think are important for us as a society. In terms of testing, that's probably the best thing we could do. In the New Orleans area, for instance, drive-through testing was the only way that a person could get the test if they were symptomatic. However, we know from Katrina, the people who were left behind did not have cars and could not evacuate. And similarly, there weren't areas where a person who lived in certain communities could just simply walk and get testing. You look also in terms of employment. We're now just being sensitized that grocery clerks, transit operators should have the same type of personal protection that we see in our very heroic healthcare providers in ERs and ICUs. They also get exposed and die more from COVID-19. Education. I think it's important that we have the education which is targeted appropriately, culturally, with a literacy level that's appropriate. Those are big words. What does that mean? We need to talk to the patients in a straightforward manner, using language that they understand, and having those people who deliver the message, people whom they trust. Many African Americans don't trust doctors. We know this from clinical trials related to hypertension, heart disease, the areas that I work in. They tend not to register into trials, and oftentimes there's less adherence. And it's not because of a lack of intelligence. There's a real legacy in conventional medicine of bias and maltreatment of African Americans. So there's less trust in the healthcare system. So a combination of structural changes in how people are treated in the workplace, increased testing, not just drive-through, but going into the communities and targeting those patients, and health education that's culturally appropriate, literacy appropriate, straight talk from people who look like them and can talk their language will help a better understanding. I can tell you personally, and this is going to sound odd to our general community, but this is personal communications directly to me. At one time, Black patients were saying, well, I heard that Black people don't get the coronavirus, that it's something that doesn't affect us. And that's just absolutely not true. So it's important to do a combination of testing, outreach, education, and personal protection for people who often work, custodial workers, grocery store clerks, transit operators, who serve us in essential ways, but not have been gotten this type of protection that they needed in the past.
Thank you, Dr. Ferdinand. We're going to come back to that topic. Dr. Mclaughlin, let's start with what you do for a living. So
Sure.
You're an immunologist. For those of us who aren't in the medical or research field, tell us a little bit about what that means.
Sure. So I was joking with Dr. Roy and my friend James Dennis yesterday that an immunologist is someone who studies the immune system, but that's obviously pretty simplistic and circular. So I was thinking an analogy, and I think the best analogy is, so if you think of your body as a country, say the United States would be a good example. The United States has, 5 branches of the military. So you have the Army, the Navy, the Air Force, the Marine Corps, and the Coast Guard, right? And all of these branches sort of work in tandem to defend the country against foreign invaders and threats. Some of them have overlapping duties, and some of them have very distinct duties. So the immune system is actually very similar just for your body. So your body has sort of all of these things that are like, sort of like the military, and they have soldiers cells that act a lot like these military branches. They sometimes have overlapping duties, but they have a lot of distinct duties as well. And so what we try to understand as immunologists is how these defense forces sort of in your body, much like they do in the country, how they protect you against infectious diseases like viruses or bacteria or parasites. So that's sort of the main idea is how do we understand the defense force of your body, the military of your body is really what that is.
So following up on that, we hear a lot about suppressed immune systems being at higher risk. What is a suppressed immune system?
Yeah, sure. So I think Dr. Ferdinand probably could talk about this as well. But so the idea is that when your immune system works at full capacity, it should be pretty good at protecting you against most infectious diseases. And we get a cold, we may feel sick for a little while, and then we start to feel better. And that's because your immune system is working in the way it's supposed to. It reacts to the cold virus. It starts to make a variety of different chemicals and molecules that then act to basically kill and destroy the cold virus. And so in the case of a normal healthy person, for most infections, sometimes we don't even realize we're infected, and our immune system does a really good job of getting rid of that infection. For some infections, the coronavirus is an example, our immune system can't always control that, although for most people, it's actually pretty good. When our immune system is not healthy, in the case of I guess one good example would be in the case of cancer patients who get chemotherapeutic drugs. In many cases, their immune system is suppressed. It means that their immune system no longer is able to react normally. It can't respond to infections. It can't behave like it normally would. And so this idea that certain kinds of outcomes are suppressed by either drugs, things for chemotherapy for cancer, or drugs that suppress the immune system for transplant patients. Those are specifically designed to prevent your immune system from responding normally in the cancer setting, but it also suppresses your immune system in the infectious disease setting. And so this idea of immune suppression is when your immune system isn't fully healthy, then it can't respond normally, and therefore it just can't control the virus. And particularly the coronavirus, I think this is a real problem because this virus, even in healthy people, can cause disease. But you can imagine in a person whose immune system is not fully functional, it can cause even more severe disease.
Thanks. Dr. Ferdinand, did you want to follow up on that?
Yeah, clearly the immune system plays a big part in how we respond. We know older persons have more death from COVID-19, but even younger persons, when they have these comorbid conditions, for instance, diabetes and obesity, there are inflammatory markers that are released in these conditions. And we know for a wide range of infections, not only viruses, but also bacterial infections like pneumonia, that persons with diabetes have an increased death and disability. So if you have a population, let's say the African-American population, that has higher rates of diabetes, obesity, and these other inflammatory conditions, and now you enter this terrible toxic virus into that particular environment, they're going to have more infection from that environment. So we're not sure whether or not it's more infection, but we clearly are sure that the results, if you have those comorbid conditions, is that you have more of an inflammatory response and an increased death with an infection.
Dr. Roy, Dean Ham mentioned earlier that the Primate Center had gotten about $10 million to develop a COVID model. Can you tell us what that means and how that money will be used?
Sure. So the NIH awarded a contract to Tulane and specifically the Primate Center. I'm involved in that. I'm the lead researcher on it, primarily to develop an animal model of this disease. And why is that important? Well, right now we don't have scientifically any of the real tools to study the pathophysiology as it relates to transmission of this disease. We know clinically how it's transmitted through epidemiological study, but biologically work in the context of the disease. We need a tool to do that. And one of the greatest tools that we have is a non-human primate. And so NIH has entrusted us with that job to figure out which species of primate will faithfully recapitulate human disease. And we're gonna do that in a series of experiments and studies to do just that, figure that out, and all the specifics around transmission and how the disease progresses. That's going to do two things. That's going to allow us to study the disease itself and make conclusions about why some people have exacerbated disease, as Dr. Ferdinand talked about and Dr. Mclaughlin. But also it gives us a test bed to test vaccines and therapeutics that ultimately will save lives in this. We have to have a tool that will allow us to understand how the vaccine works, how it affects the immune system, and some of the things that Dr. Mclaughlin talked about, and then how it protects. Are antibodies developed that would be consistent with protection before we put it into human populations? Because we need to be supremely confident of those therapeutics and those vaccines that are being developed right now. And there's a lot of them that are coming out. A lot of people are at work here at Tulane, but all over the nation and world really, on developing those what we call medical countermeasures to do that. If we don't have a sense of the safety and added benefit or efficacy of those products in a animal model, then it's a big crapshoot and a big risk in putting that into a clinical setting. What is so difficult about this challenge is that there is such an urgency with this virus and this outbreak that there's an absolute rush to develop what normally takes 8 to 10 years in months. And I don't know about everybody else out there, but September, October of last year, nobody even knew about COVID-19 and this coronavirus. So, you know, when you get down to the base of all these different scientists and physicians and everyone else working towards vaccines and therapeutics ultimately to help, it's just a mad dash. So this is one of the steps that NIH, which is a premier health agency really in the world, has entrusted Tulane to do, to be the de facto testing center for many of these things that are being developed. So it's a lot of hard work. We were joking, somebody said the other day that I received the $10 million or so dollars. I didn't receive the $10 million. Tulane received the $10 million. It's going to give us the resources we need. The School of Medicine, the National Primate Research Center, to do this hard work and very important work to develop that model.
Thank you. Dr. Ferdinand, what is the importance of the inflammatory response in COVID-19 and their relation to pre-existing chronic inflammatory conditions such as CVD and HIV? Is it amplified?
Yes. Yeah. You know, we often think of vascular disease in the blood vessels, heart disease, metabolic diseases, diabetes, obesity. We often think of these as passive procedures where you just check the glucose, you check the blood pressure. But actually underneath those numbers that we measure on a regular basis have been shown to be inflammatory responses. There's something called high sensitivity C-reactive protein. Big words. It's a protein that the body releases when there is an infection. Well, that same protein is higher in persons who have diabetes and underlying heart disease. So we have a person who already has an inflammatory state with vascular disease and metabolic diseases. We now introduce this virus, and many times the body will then have an overly active inflammatory response. We actually have a term for a cytokine storm, and it inflames the lungs, it inflames the heart. You can get an infection in the heart that looks just like other viral infections of the heart, and it's probably the main pathway to death and disability from the virus. I'm going to build just really quickly on what Dr. Roy was saying. He's going through this painstaking process of trying to find a model by which we can get a vaccine or find the appropriate anti-vaccine, antiviral agents to compete against COVID-19. And people will say, well, why go through all of that? The reason is because in the past, we've gone down dark alleys where we thought a particular vaccine was beneficial and it either didn't help or it caused harm, or we thought a certain medication was beneficial and found that it had very severe side effects. So we have to be really careful of, well, let's just try this and try that, because many times drugs, vaccines will not only not have a benefit, but they also may be toxic.
Just to follow up on that for a second. So there's a lot of talk about, I'll not pronounce it correctly, chloroquine, how it might affect patients taking metformin and how it affects other patients. Can you talk a little bit about that?
Well, that's one case. There's been some anecdotal responses to hydroxychloroquine suggesting that it tends to blunt this inflammatory response and makes an environment where the virus doesn't thrive. But it's really anecdotal, meaning it's like stories. It's the whisper thing we used to do when we were in kindergarten, where you get in a circle and one person tells something in the ear, and by the time it comes around a circle, it's something else. It's just stories. We also know that in some patients, especially those who already have heart disease, and remember, people with heart disease and older persons have an increase in death from this particular condition, that if they have a certain condition where one part of their electrocardiogram, called the Q wave, is distant from another part of their electrocardiogram called the T wave, they call it QTC prolongation, that they actually can get in a rhythm where the heart beats really rapidly out of control and can actually cause sudden death. So here's a drug which may be beneficial, but may also be very harmful. And the way that we find out whether or not that's true is by doing clinical trials. We don't find out whether it's true by just telling everybody, take it, take it, take it, because it looked good in a few patients that had previously been reported in France and in China. That's just not the way medicine works.
This question is for both Dr. Mclaughlin and Dr. Roy. So as it was put to me, I think this was from the public, a veterinarian, immunologist, microbiologist. Due to the complexity of the immunology of reptiles, dogs, and cats, should we worry that these animals can harbor this virus silently longer than it takes humans to get over the virus? And what precautions should we take when caring and handling home pets? Anybody?
You can take that one.
I figured you were going to throw that to me. So I'm trying to think of how I want to answer this question. So I think it's probably important to understand off the bat that the immune system, at least in mammals, across almost all mammals, is very similar. It's not exactly the same, but it shares a lot of the same functions. And so it can combat things in similar ways. A lot of the differences in viruses like these and other pathogens that infect, dogs but don't infect people, or infect people but don't infect monkeys, or although that's even closer, or cats, is probably less dependent on the immune system and immune response, and more dependent on the other cells in the body that can be sort of be attached to by the virus or attacked by the virus. I'm not a virologist, so I don't want to pretend that I know a lot about viruses in this way, but I do think it's important to start thinking about the possibility that there is some sort of species movement back and forth. And I think Dr. Gary, who's been on this town hall a number of times, I think, has already talked a little bit about sort of this particular virus potentially originating in bat populations in China. And so that sort of jump from bats to humans can happen with these kinds of viruses. And I think I don't know the answer. I don't know that any of us can really know the answer about whether it jumps to companion animals. I would hesitate to ever say that's true. Mostly, honestly, because I don't think it probably happens very often, and also because I don't want to give anyone the impression that their companion animal is a danger to them, because I don't think they are. And I'd hate to see a lot of companion animals abandoned because people think their animals are infected with this virus, which I don't think is true. So, and it's clearly not infecting dogs. I think we know that's true. There was one case of maybe a tiger being infected, which is, you know, sensationalistic because, oh my gosh, a tiger's infected. That's kind of cool to think about. But I don't know that there's a lot of evidence that it crosses species right now. So I don't know if that answers your question, but I feel like it's a weird answer. The immune response probably is going to be similar depending on the kind of infection. But Dr. Roy?
Sure, I'll just follow up. That was a great answer, Dr. Mclaughlin. That different species, including human beings, have different, what we call permissiveness in terms of viral infection. And so there's a lot. I mean, we're still learning about the human being infection and our state in the context of how we transmit this virus to one another, how long this virus stays with us. And we don't really have an animal model right now that can give us a feeling definitively on transmission, but also how long the virus stays with you. And if you enter into what we call a convalescent state, to where you're recuperating from the virus, and if you cannot be reinfected. So those are two different things: reactivation of a virus compared to a reinfection of a virus, which can happen with other viral infections. But we don't know that really definitively about this virus. So for us to estimate or postulate about different species and the kind of the kinetics and dynamics of transmission and infection is very, very difficult, because we don't have those tools. And, you know, we, as scientists always say, and physicians always say, let the data lead us, right? We don't have that data right now. This is brand new. And so, you know, it's to make estimations about that, including transmission from a dog or a cat or that kind of thing, is very, very difficult at this point. I think once we have the human condition under a little more wraps, like say what we know about influenza and how influenza is transmitted, how it transmits from infected human to naive human, for instance, and that process, how long it stays with us, and our body's ability to control that viral infection. That'll be the first great step, and then the veterinary and things like that, I think, will come in good time. But right now, it's, you know, it's very difficult to generalize even with those types of infections.
So this question is for the panel as a whole, but I'll start with Dr. Ferdinand. Can you speak to the dangers of prematurely lifting restrictions of the stay-at-home mandates, social distancing, even if it's in certain areas of the country and not in other areas of the country? And any guidance you could give us on the best way to protect our families as we shift away from those restrictions?
Absolutely. Absolutely. First of all, let me address just the idea of the virus ain't that bad. If you look at the 31,000, 32,000 deaths we've had thus far, and people will say the conventional flu kills 35, 40, 50,000 people a year. So it ain't no bad, it ain't no worse than the flu. When you hear this, people say that. Let's think clearly. This 31, 32,000 deaths we've had has been in 4 to 6 weeks. Flu season starts in September through April. So now you're talking about 4 or 5 times 30. You're now up to 120, 150,000 people dying if it is prolonged over the next several months. And I really don't understand how people get on national television and take a death rate for a condition, the flu, or car accidents, and look across 12 months and then say, well, only 32,000 people have died with this, so it ain't worse. It's almost as though they don't have simple math and understand that if you have the same death rate that you would have and you extend it out over 4, 5, 6, 7 months, you're going to have that 100, 150,000. It's such a simple concept. I have no idea why that continues. The second thing is, when you look at the flu, we already know that people who are over 65, persons who have diabetes, sickle cell, have very high death rates from conventional influenza. So it is absolutely no surprise that older persons, persons with diabetes, cardiovascular disease, are going to die more from this form of a virus. The third thing is that people will say, well, they said it was going to be this 100,000, but look, it's only 30-something thousand. That's like saying you have a heart attack, you go to Tulane emergency room, which is a certified heart attack center. Cardiologist does an angioplasty and stent, opens up your blockage. They put you on medications, give you oxygen, they revive you, and you walk out 2 to 3 weeks later and you say, I had a heart attack, I survived, I'm fine, it ain't that bad. Well, the reason it ain't that bad because you had treatment. The reason that we're seeing the plateau is not magic. It's because of social distancing. It's because of hand washing. It's because of the hospital treatment that's being given at a very high and costly level. So what I would suggest, to answer your question directly, is that it will be foolhardy, because it's 75 degrees and partly cloudy in New Orleans today, is that you say, it looks fine to me, I'm going to go out and have fun and hang out with my friends. Because your friends may be asymptomatic with COVID-19, shed virus, infect you, and especially if you have those comorbid conditions, diabetes, hypertension, obesity, asthma, you may die. And that's the type of thing that I think we need to talk to our people about, and not use these false, specious discussions of it ain't that bad because only 30,000 people have died, and in the flu, more people die. Look how many people die from car accidents. It's really foolish at a very simple level. And if I sound agitated, it's because I think that's miseducation. It's misinformation.
Thanks. I think we should I actually love this. I think we should just redub it what Senator McCain used to call the Straight Talk Express. That's what's needed, I think. Dr. Mclaughlin, Dr. Roy, do you want to weigh in here?
Yes, well, and I'll speak a little bit about kind of the premise of what Dr. Ferdinand was talking about in terms of the virus itself and what we're learning every day about the hardiness of this virus relative to infection, and some of the outcomes that Dr. Ferdinand brought up. It's important, and one of the things that we're working very hard on, and not just here at Tulane, but very specialized labs throughout the United States and the world really, is to understand transmission. And what I can tell you is that there's a growing body of evidence in the data that shows that this virus is an altogether different beast than other viruses that we know to be pathogenic in human beings. And what I mean when I say that is that the tenacity at which this virus can move through our environment and be stable and maintain infectivity in things like what we call fomites, where aerosols settle out on surfaces and can remain infective, that people can come into contact with and expose themselves, as well as in aerosol, and which is a lot trickier in terms of defining. We're doing important work on the characterization, right here at Tulane in my laboratories, in the aerobiology laboratories trying to understand that phenomena so it can inform in terms of disease outcome, our model building, the animal models that I talked about, as well as preventive measures. So if you have a growing body of evidence, and remember, we've only been at this for 3 months, that is showing that it is an altogether different virus in terms of its tenacity and in the environment for potential for transmission, then the transmission patterns can be altogether different. And so that's why it's so important that when we have these public health messages that say to do certain things, it's not just hot air, especially, which, you know, we do it as a society, we always harken back to what we know, right? About influenza or other things. The science right now is telling us that this virus is going to transmit in an altogether different pattern than some of our other pathogenic viruses that we deal with as human beings. And that's developing, that's happening right now in real time. And and I know it's kind of a random thought, but you know, when you don't understand the dramatic nature of it, how it is different. But I'm telling you, there is a growing body of evidence that shows that, and is suggestive of that. And when we see those types of bright lights in the science, then everyone should pay attention. And so that's just to reinforce, you know, the very important things that Dr. Ferdinand's brought up here in terms of transmission and outcome, is that the first part of it, that transmission part from infected individual to naive individual, supports that and that message. So it's critical that everyone pay deep attention to public health messaging as it is right now, and let that guide us, because the science isn't locked up by any means. It's in real time, and it's a, you know, honestly a pretty scary thing when you think about it, that we're doing this in real time. Yeah, so that's.
So Dr. Mclaughlin, let's
sure.
make it even scarier. Actually, let me follow up on the question is,
Sure.
what is the risk that this novel coronavirus will mutate so that we don't have so there's no immunity to a newer virus?
So again, I'm not a virologist, so I don't want to speak to it from the virology side, because I think probably Dr. Gary or someone else would be better at that.
Okay.
There certainly are some reports that this virus may be mutating. It may actually be mutating the part of the virus that attaches to cells. So that could certainly confound things, right? Because I think in a lot of cases, when we create a vaccine or we have immunity to something, it is to very specific parts of that. And we can talk about that in another town hall if we ever get a chance. Again, I would love to sort of discuss this at length. But I think, you know, I'd love to speak to sort of what Dr. Ferdinand and what Dr. Roy were both saying. From an immunological standpoint, I think what we don't yet know. So oftentimes if we get infected with a pathogen, a virus or a bacteria, we develop a really great immune response. It remembers that particular pathogen, bacteria, or virus. And then when you get infected again, you often have a minor illness or no illness at all. Your immune system takes care of that. We don't know yet whether that is true for this particular virus. And that's, for me as an immunologist, strange and a little potentially unnerving, because we don't know yet if you can be reinfected. We don't know. I mean, there's some anecdotal data or an anecdotal evidence maybe from South Korea that folks who have been infected are maybe being reinfected. And that's sort of unusual in the case of these kinds of infections. So I don't know yet that we can say if you're infected, you then can go out and work and you're healthy and you'll be fine. That's, I think, like Dr. Roy said, we're so early in this, we're so new to this. I don't know that we we necessarily can make those conclusions as much as we would love to. The data has not yet shown us that that's true. One possibility is to take, and this is, there's an old method where you take blood from people who've survived an infection. People, this used to happen for the 1918 flu pandemic. You would take blood from one person, you would purify it, and you would transfer it to a sick person, and the immune components that you transferred could actually protect that sick person. I know that that's been talked about and maybe even being tried in New York because they're being hit so hard, but I'm not sure, aside from more anecdotal evidence, that that's working as well. So I will echo what Dr. Ferdinand and what Dr. Roy said. The public health experts in this case are the experts, and I think if they're saying stay apart, they're saying don't have gatherings, it's for a good reason. And Dr. Ferdinand is probably really seeing this in real time and what this can do in a hospital to patients. The rest of us are just trying to keep our distance, which is why I'm in my wood shop now talking to you. So.
Dr. Ferdinand, we talked a lot about underlying factors, but there are a lot of people out there who have hypertension, a lot of people who have controlled hypertension. Would that increase the severity of COVID-19?
Well, in general, in medicine, it's hard to do a cause and effect. Remember that being older increases the chances of dying from COVID-19. Hypertension increases as a person gets older. So people who are over 65, most have hypertension, and they get increased death with COVID-19, but it's hard to prove that the hypertension is causing it. I think the hypertension does cause damage to the vasculature. It often weakens the heart. It often weakens the function of the kidney. And we know in observational data that people who have heart disease and kidney disease also die more. The pathway from diabetes, asthma, and chronic lung disease is probably a little bit more direct because diabetes is an inflammatory condition, and the COVID-19 will increase the inflammatory storm that you have. And we know that if you have underlying lung disease, COVID-19 is a respiratory infection. So you have inflammation, scarring in the lungs, and you've already had lung disease. Now you're building your house on quicksand, so you're going to be more prone. But specifically saying hypertension causes death with COVID-19 is not as direct as with the metabolic conditions and as direct as the lung conditions. I'm going to say this really quickly. I just thought of something that our audience may know that can kill you, but it's 75 degrees and sunny outside and you don't see anything. High cholesterol. People who have cholesterol, LDL cholesterols of 190, 200, we have observed those persons for hundreds of thousands of populations. They have more heart attacks, strokes, and they die. But they feel pretty good, and that's why they don't get the treatment, they don't seek care because they have no symptoms until they have the heart attack, stroke, or die. It's the same with COVID-19. The virus is real. This is not a game. And just because you don't see anything doesn't mean it's not deadly.
So we're almost out of time, but I want to sort of go backwards from the way we started and ask you guys, what keeps you up at night right now about this? Dr. Roy?
Let me go first.
Okay.
Because I'm up every night and I'm thinking about this. It is really simplistic that we think that we have hit the plateau and we're bending the curve or stumping on the curve or doing something to the curve. If the virus is still present in the environment, whether you're rural, urban, black, white, Hispanic, non-Hispanic, if the virus gets in that population, it's going to kill people.
Okay.
Dr. Roy, I guess I'll do it. From a scientific standpoint, I would say what I had talked about a little bit earlier is that we're going to have a hard time making something that can actually prevent reinfection with the disease. I feel like I'm competent in the scientific community. I've worked with some of the most incredible and talented immunologists in the world, and I think if anybody can do it, it's this group of scientists. But that's I guess that's what keeps me up at night. This is going to be kind of like the cold or the flu. It's going to become cyclical. The problem is I think it's as Dr. Ferdinand has pointed out, currently it is more more lethal significantly probably than the flu, and certainly more than the cold. So I'm worried about, coming up with something as quickly as we need to. That and my kids not being able to go back to school, that's the other thing.
Dr. Roy?
I'm worried about the kids not going back to school either. So I'll agree with Dr. Mclaughlin on that one. The world of infectious disease aerobiologists is a very small part of science. We don't have a lot of us in the United States or in the world. And we've all collectively been working together on this ever since this outbreak took place. And since it was first reported as a, unknown pneumonia in the Hubei province of China. And what keeps me up at night is that we continuously, and this is as a group, and this includes my labs here at Tulane, feel like we're behind the curve on understanding the wildlife ecology and the aerosol ecology of this viral pathogen. I've worked in infectious disease aerobiology for over 20 years, and at the risk of aging myself this is a very peculiar virus of all the different viruses that I've worked with, and I've worked with a bunch of them in this context. And so we're all sharing data, which is great, trying to understand this in terms of infectivity and the size of the particle and all those different things, working, hand in glove with virologists and others on that. So when I think about at night, what we need to do and how we need to do it, it's such on an accelerated pace that I start getting nervous and concerned that we're not going to be able to get it done quick enough. So, we're all working very hard. Everybody that's involved in this, my laboratory right now is a beehive, is an absolute beehive of activity. And there's individuals that are working incredible hours just to get this done. So that's the kind of thing that, makes you feel guilty going home at night when people are working that hard. So that's the kind of thing that keeps me up at night.
Thank you all. And I would say that we need all of you to beat this. So practice self-care, please, all of you. Dr. Ham, do you have anything you want to close? Still on mute. There.
I just want to thank all the panelists for their insights. Thank you, Sharon. Thanks for those that helped put this on. Stay safe.
Right. Thanks for watching today, and continue to send us your thoughts and notes about future town halls, and have a great weekend.